Hello, my name is Vinay Badwar. I'm joined by an esteemed panel here at the STS annual meeting in Houston. I'm from Morgantown, West Virginia, and chair of the Public Reporting Task Force for STS. And I'm joined by David Shahian, professor of surgery at Harvard and the vice president of Mass General Center for Quality and Patient Safety, and also chair of the STS Council on Quality Research and Patient Safety. Jeff Jacobs, who is professor of surgery at Hopkins, is also chair of the STS Workforce on National Databases, and Benj Kozauer, professor of surgery at WashU in St. Louis, who chairs the General Thoracic Surgical Database Task Force. Today we're going to discuss public reporting and some of the controversies and some of the outstanding progress we've made in public reporting. Public reporting itself is steeped in the history of STS itself and the database, going back to 1989, the inception of the database and our goals for transparency, and really exercising the moral obligation we have as a society to be transparent with data. And so I'd like to start this out by going back a little bit of history and why public reporting in STS sets the stage for excellence and transparency among other medical societies. Currently, in the United States, there are elements and companies and states that publicly report both hospital level and surgeon level outcomes using a sundry of different data sources. In the STS, we have what's known as the Quality Measurement Task Force that looks at robust risk models. Dave, you've led this initiative since its inception and led the Quality Measurement Task Force on really developing robust risk models for assessment of quality, and public reporting is merely a mirror of that strong basis in scientific assessment. So how do you answer the question to a surgeon or a hospital saying, well, we do really high-risk operations, and if we publicly report, it may not justly reflect what we are actually doing?
So Vinay, you've brought up the important issue of risk aversion in a public reporting environment, and that's probably the major reason that people object to public reporting. But let me turn that around and start off with why we should publicly report, and then I'll get to your question. I think first and foremost, we believe in the Society of Thoracic Surgeons that this is our responsibility to the public. We have an ethical responsibility to be transparent and to be accountable. Now this has some practical consequences. We believe, for example, that this will better enable patients and insurers, families to look at data, objective data, and to use those data as one part of the decision-making process. This may shift patients towards higher performing programs, particularly the high-risk patients where there is some evidence that I'll talk about in a second that higher performing programs may actually have better results. It's also one way to improve quality. It's not the only way to improve quality, but clearly we have evidence that publicly reporting programs have higher outcomes overall. And one final reason, again, a very practical reason, is that there are so many poorly constructed report cards out there, many of them being published by commercial entities, for example. These report cards are based on data that's not optimal, on methodologies that have never been fully vetted. We have to have a counter to those sorts of poorly constructed report cards, and publicly reporting our own metrics based on clinical registry data and very sophisticated statistical models. We think that's the best way to counter those bad report cards. So back to your original question, how do you respond to the person that says, well, I get these really high-risk patients, and I'm afraid that my case mix is not going to be adequately accounted for. We actually have looked at this in a couple of different ways, but I think probably one of the most definitive papers on this, the first author was Brian Englum in the Annals of Thoracic Surgery a couple of years ago. I was privileged to participate in that study. We looked at the 2009 CABG results nationally, and we divided hospitals into quintiles by their expected mortality rates, and they range from about 1.5% up to 3% in the highest risk quintile. A couple of interesting findings in that study. First of all, it corroborated what we found from many other studies, namely that all our risk models, probably all risk models in healthcare, tend to slightly over-predict at the high end. So that means that they give you a little bit of cushion, and that's not intentional. It's just probably relates to the statistics behind some of these closely related high-risk factors. But there is a little bit of cushion. But the other very important finding is that of all the quintiles of expected mortality risk, the hospitals that were doing the highest risk patients with an expected mortality rate twice that of the lowest risk, those hospitals had and programs had the lowest ODE ratios, about 0.8. So they were doing well. They were protected against those high-risk patients adversely affecting their report cards. And I think it should give reassurance to those programs that are taking on those high-risk patients.
So to summarize, the observed to expected ratio of mortality and major morbidity, because of the robustness and the scientific validity of the risk models, which incorporates all of the major risks that are associated and recorded in the STS database, it is protective, actually, to surgeons and hospitals that are taking on those high-risk patients. So the issues of risk aversion are really not valid in our form of the robust database-driven risk models.
We think we have the best risk models in healthcare, and we've just finished a complete revision. It took about a year and a half. So it's about as good as it gets for risk protection.
Well, you know, some of the issues in public reporting can be controversial. However, based in the same risk models in adult cardiac surgery, there's been a mountain of work in the same approach to pediatric surgery and pediatric heart surgery. Jeff Jacobs has led that initiative for many years in developing robust risk models for congenital surgery, and it's of value not only to hospitals, to physicians, but most importantly to parents, and how one interprets where and why to take their children for surgery. So, Jeff, can you highlight, some of the recent progress in the congenital approach to public reporting?
Sure. Well, first of all, one should consider what is the rationale for public reporting. Why do we publicly report? And very similar to what Dave said on the adult side, we have pretty solid fundamental reasons for why we believe public reporting and transparency is the right thing to do in the pediatric cardiac surgical community. First of all, ample data shows that variation in outcomes exists across pediatric cardiac surgical programs. Then, we believe that patients and their families have the right to know the outcomes of the treatments that they're going to receive. And we also believe that it's our professional responsibility to share this information with our patients and with their families, with their parents, in a language and in a format that they can understand. So that provides the rationale for public reporting really across the entire STS database, but also in the specific world of pediatric heart surgery. In order to successfully publicly report pediatric cardiac surgical outcomes, we had to address many of the issues that Dave just described. There's concerns about risk-aversive behavior, and we would also agree that the solution to risk aversion is proper risk adjustment. And therefore, years of work went into the development of a risk adjustment model for pediatric cardiac surgery, which we're very confident is currently the best risk adjustment model that currently exists for pediatric heart surgery. This is a model that was developed from thousands and thousands of operations at multiple hospitals across the United States. The model adjusts for the operation performed, the age of the patient, multiple preoperative factors that affect the risk of the patient going into that operation. Factors such as, is the patient on the ventilator? Is the patient on mechanical circulatory support? Did the patient have a stroke prior to the operation? Did the patient have renal failure prior to the operation? Does the patient have a chromosomal abnormality, a syndrome, a non-cardiac abnormality like a diaphragmatic hernia? All of these factors are placed into our risk model, which the data shows is the most sophisticated and most precise risk model that's ever been developed for pediatric heart surgery. One way to measure the usefulness of a risk model is to look at the C-statistic of a risk model, and a C-statistic can range from 0.5 to 1.0. 1.0 would mean it has perfect correlation. 0.5 means it's a coin flip, a 50-50 coin flip. And the congenital heart surgery risk model that we currently use for public reporting has a C-statistic of over 0.085, and that's the highest C-statistic that's ever been achieved in pediatric heart surgery. Using this risk model, we can calculate the expected mortality of any program for their specific case mix. The database tells us what the observed mortality is, and then we can make a fraction of what the observed mortality is in the database divided by the expected mortality generated from the risk model, creating an O to E ratio. If a hospital is performing exactly as expected, the O to E ratio is 1. If the hospital is performing better than expected, the O to E ratio is less than 1. If the hospital is performing worse than expected, the O to E ratio is greater than 1. To assure that the differences are not due to random chance, we place confidence intervals around the O to E ratios, 95% confidence intervals. And if the 95% confidence interval is completely less than 1, that is a program that we would say has performance that is better than expected. In an STS website language, that's a 3-star program. On the other side, if the 95% confidence interval is completely on both sides greater than 1, that's a program that has a higher mortality than one would expect, and therefore it's a 1-star program. And if the 95% confidence interval overlaps the number 1, overlaps unity, that's a program that's performing as expected and is classified as a 2-star program. This model is the basis for public reporting. It's quite accurate. It has very good risk adjustment to prevent risk-aversive behavior. And I think that the very fact that more and more programs are publicly reporting shows that it has generalized buy-in in the pediatric heart surgery community. When we went live with the model in 2005, 23% of the programs agreed to publicly report. And by late 2000, that was 2015. And in late 2016, over a year later, we're up to about 60% of the programs in the country publicly reporting. And I think that shows, that growth in a year and a half tells us that there's generalized support of this approach in the pediatric heart surgery community in the United States.
So thank you, Jeff. I mean, it's been a tremendous embrace by the majority of pediatric hospitals and programs to embrace public reporting, and that's faith in the models. You know, a lot of the risk models developed for cardiac surgery are somewhat different when we approach thoracic surgery. And some of the most exciting developments we've been working on for the last year plus now are in the realms of general thoracic surgery. And Benj Kozauer, as the chair of the General Thoracic Surgical Database Task Force, and several of our colleagues have worked very hard to address one unique issue, is that for many general thoracic operations, there are providers that are maybe not STS members and not actually thoracic surgeons that are operating in the chest. And that sets up a difficult problem with the denominator of how one assesses quality in hospitals in the United States. And Benj and the team have worked very hard to come up with a unique way of assessing how we should address public reporting, how we should do report cards. And Benj, could you tell us the progress we've made over the course of the last year and describe kind of what our first step is in analysis?
That's great. Well, thank you very much. I want to thank the three of you for helping us do this. Definitely been a long road, and I think we've intentionally been very deliberate in how we've approached it. As you mentioned, the penetrance of the thoracic surgery database is quite a bit lower, probably around 50%, capturing 50% of the lung cancer resections that are performed nationally, which is quite a bit below what happens in both the adult and the congenital databases. And so to address that, we wanted to first compare the Society of Thoracic Surgeons database with what happens nationally. And so we've shown in some previous work that the STS participants outperform what happens throughout the whole country. And so what we didn't want, for example, is a STS program to get a 1-star rating, which is below expected performance, and yet be as expected to what happens in the whole country. So to represent that, we've used the National Inpatient Sample, which is probably the most generalizable data source for the entire country. Again, it's administrative data, so it's not perfect, and we're very transparent about that, and there are pros and cons. And so we're going to have a 2-part comparison. So the first thing we're doing, and fortunately we just actually went live this week, and excuse me, so we have now went live on the website. You can see who's participating in the STS thoracic surgery database. And then you can also see comparisons of STS participants with the National Inpatient Sample. The 2 things that we can compare directly are discharge mortality and also hospital length of stay.
And so just for clarifying, so some of the people watching this are maybe not surgeons and hospital administrators and the public. So we're using the National Inpatient Sample to look at all thoracic operations done in the United States by even non-thoracic surgeons. And that way, comparing appropriately thoracic surgeons versus non-thoracic surgeons using this combined way.
Right, and when we say thoracic surgeons, people think of it differently. You know, so for example, in the lobectomy composite, which is what we're talking about that just went live, it's the most common operation performed by general thoracic surgeons. Our database is primarily composed of dedicated general thoracic surgeons. So they're board certified in cardiothoracic surgery, but don't do cardiac surgery. What happens nationally is about 70% of board certified cardiothoracic surgeons do some thoracic. The volume of those procedures, I think, has great variation. And then there's also some general surgeons doing some lung cancer and esophageal cancer work. So it's just a very different landscape.
And so that makes it unique for us to appropriately judge, unlike cardiac surgery, they're all cardiac surgeons and they're all CT surgeons and STS members usually, and the penetrance of cardiac surgery done in the United States is upwards of 90 to 95% captured in the database. Not so in thoracic surgery. So this is a unique situation that we've worked very, very hard, and Ben has led this initiative to address this in the most scientifically valid way we can. And so in January of 2017, here at the annual meeting, we've just launched the beginning of the public reporting initiative for general thoracic surgery. So tell us what's next. We've got a lot of plans now. As this rolls out, what's our next approach?
So it's a great question, and we are working hard with our participants, and we will hopefully this summer start to do reporting within the STS. So we'll be launching the same campaign for excuse me, information and education, so that we can then also compare within STS participants. And the other exciting thing actually being presented tomorrow morning as a Clark paper is we have created our second quality composite, which is esophagectomy for esophageal cancer. And it's very interesting as we talk about these issues, but our ability to provide programs with a star rating is also quite different. So in our lobectomy model, about 3/4 of participants will get a star rating. Everybody who participates will see their outcomes and be able to see where they fit in the scheme, but some people, some programs just don't perform enough procedures to reliably give them a star rating. It's even a bigger issue on the esophagectomy side. The benchmark was 5 procedures per year. So it's only 15 procedures over 3 years, and yet almost half of programs don't meet that bar. And so it's going to be a real issue for us to come up with a quality measure and a composite that is applicable to all participants.
It's very, very important, and we encourage all thoracic surgeons to participate, because as we increase the denominator, the science is better, the models are better, and it's stronger, and it's for everyone. So thanks for your leadership on that. Well, I want to wrap up with a couple of other important items. recently in the country, there have been many entities and some states that have not only entered the field of public reporting using report cards for hospitals, but also reporting surgeon-level outcomes. And that sets up a sundry of different ways when one is compared to one's peers using data that may be suspect or may be claims-based data. Well, several years now, we've been planning a surgeon-level effort within the STS database, looking at very robust risk models, and Dave Shahian's led that charge. And could you maybe tell us the progress we've made and how we might wade into this? And we're doing this very purposefully and very carefully and diligently. Can you help describe this for us?
Sure. Vinay, you're absolutely right that historically the Society of Thoracic Surgeons has focused on program level, typically a hospital level results, for a couple of reasons. First of all, it's a team sport, so focusing on just the surgeon may not be completely appropriate. And then secondly, when you're looking at surgeon level results, you have far fewer observations. It makes it much more difficult to accurately assess performance. But notwithstanding those caveats, we have been involved for the last several years in preparing for surgeon level reporting because it's out there, and we want to have something that's highly reliable and accurate at the surgeon level. So we actually devised a surgeon level composite that's based on the 5 most common procedures that an adult cardiac surgeon would perform. It's based on 3 years of data, and it's based on a composite outcome, which includes both risk-adjusted mortality and risk-adjusted occurrence of any of the 5 major complications that we historically have studied. So that obviates some of the small sample size issues, provides a comprehensive measure of individual surgeon quality, and surprising even to us, this very complex model, which takes about 10 days to run on a dedicated server, it's so complex, but it has a reliability of over 0.8. I think there's very, very few measures in healthcare, even in cardiothoracic surgery, that have a reliability that's that high. So we're going to start feeding back the results of this very accurate model to surgeons confidentially, probably sometime later this year, and then be prepared for individual surgeon reporting sometime in the next few years.
And just to highlight, so we're going to first communicate to each individual surgeon,
Right.
not to their hospitals,
Absolutely.
but directly in a confidential way. And importantly, this model helps assess what that individual surgeon's actually doing. It's not necessarily all cabbage and
That's right.
combination, but if one surgeon does the majority of aortic surgery, say, it justly addresses
It weights that aortic component more.
Right.
Exactly.
So it's not focused in our previous models on operation type. It's actually that surgeon's practice.
Exactly.
And that's an important assessment that's unique and that sets us far and apart from any other assessment that's based on claims.
I agree.
And so we feel very confident that this, when the time is right, it will be the next level. Well, the last item we want to discuss is the sort of looking back in the past and then looking to the future of public reporting. And Jeff Jacobs and Dave Shahian led this initiative since its inception in 2010, and Jeff was in my role as the chair of public reporting at the time, and is really to be credited for a lot of the leadership and progress. But we've made some associations with other entities that are credible, Consumer Reports being one. We've had a very robust and collaborative relationship with Consumer Reports on interpreting our star rating. Again, as Sid mentioned, the star rating is 1 star is lower than expected, 2 stars is actually very good. It's as expected by all these risk models we talked about, and 3 stars is better than expected. Well, one of the associations we've had is with U.S. News and World Report, and as of now, here in early 2017, the mere fact of signing up for public reporting, not necessarily getting a star rating, but just signing up would get a credit of 3% in the heart and heart surgery ranking for U.S. News and Report. So, Jeff, based on the progress when you started public reporting in 2010 and seeing its develop, now we're at nearly 60% in both adult cardiac and congenital. Tell us the progress and where you think we're going to go in the future for public reporting.
Well, thanks, Vinay. I think that was a very nice summary you provided, and I think our collaboration with both Consumers Report and with U.S. News, both collaborations are very important. Both collaborations provide additional pathways for us to share this information with our patients, with their families, and with a variety of other interested parties. The fact that U.S. News is collaborating with the STS and beginning to use STS data as their platform for assessment of programmatic performance in both pediatric heart surgery and adult heart surgery, I think that's a very good trend. As STS continues to expand our portfolio of publicly reported measures, we'll be able to provide even more measures for entities like Consumers Report and U.S. News to incorporate into their platforms for public reporting. When we started in 2010, we had a single measure, the isolated coronary artery bypass grafting composite. That then expanded to isolated aortic valve and then aortic valve combined with CABG. We then brought out our congenital model. We've now brought out the isolated lobectomy model for general thoracic. We're soon going to bring out mitral valve repair and replacement and mitral valve and repair and replacement combined with coronary artery bypass grafting. So I think one change that's going to happen in the future is that our portfolio of publicly reported measures will continue to expand. And beyond the current measures, we could see having the esophagectomy measure eventually publicly reported, perhaps some aortic surgery measures publicly reported, perhaps a multi-domain composite in the congenital arena that has mortality and morbidity being publicly reported. So I guess one big change will be the expansion of publicly reported measures by STS. And I think this expansion will be in parallel with continued collaboration with other entities that are interested in sharing this information. I think it's best, we think it's best, that if Consumers Report or U.S. News or even governmental agencies enter into the world of publicly reporting cardiothoracic surgical outcomes, the best source of that information is the Society of Thoracic Surgeons National Database. And that provides the rationale for our collaboration with these other entities. Ultimately, it all comes back to what our goal is, which is to share information about heart surgery and thoracic surgery outcomes with our patients and with their families. And I think our goal is for STS to continue to be the leader in achieving this objective.
Well, that's an excellent review. And again, you know, this is public reporting in the STS database is the tide that lifts all boats. And in our evolving healthcare marketplace, with now paying more for quality and not volume, one has to lead with providing that information in the most scientifically valid way possible. It is not as that the STS is doing so pushed by any one entity, but we're doing so based on hours of scientific validation in these risk models to really be sure that what we're doing is right and what we're doing is fairly representing thoracic surgeons, general thoracic surgeons, congenital surgeons, and adult cardiac surgeons in the best light possible. So with that and the progress we've made now and going into many different areas of both thoracic, adult cardiac, and congenital surgery, we strongly feel that the future is very bright for public reporting and for the STS. And with that, I'd like to thank our esteemed panel, Jeff Jacobs, David Shahian, Benj Kozauer. My name is Vinay Badwar.